Good day, everyone. So today we'll be discussing Module 6, which talks about the adrenergic or sympathomimetic bronchodilators. So next page po. So for the objectives, we need to, after discussion rather, the students will be able to define sympathomimetic, define adrenergic, list all currently available beta-adrenergic agents used in respiratory therapy, differentiate between the specific adrenergic agents and formulations, define the mode of action for each specific adrenergic agent and the formulation, describe the route of administration available for beta agonists, discuss adverse effects of beta agonists, and clinically assess the beta agonist therapy. So next slide po. So now we'll be talking about the key terms and definitions. Next slide po. So the first definition is the adrenergic bronchodilator. As it states there that the adrenergic bronchodilator is an agent that stimulates sympathetic nervous fibers, which allows relaxation of smooth muscle in the airway. It is also known as sympathomimetic bronchodilator or beta-agonist. So, ang isipin lang natin dito or ang pinaka-main point lang ng adrenergic bronchodilator is bronchodilation. So, it is used in asthma and bronchospasm. So, ano ba yung bronchospasm natin? Yung bronchospasm natin is the narrowing of the bronchial airways. And then, for the alpha receptor stimulation naman, it causes vasoconstriction and vasopressor effect. And in the upper airway, or primarily in the nasal passages, this can provide decongestion. So, ang isipin lang ulit natin kapag alpha receptor stimulation, it improves airflow through decongesting the nasal passages sa upper airway natin, and then it causes vasoconstriction and vasopressor effect. Now, for the asthma paradox naman, it refers to the increasing incidence of asthma morbidity, especially asthma mortality, despite the advances in the understanding of asthma and availability of improved drugs to treat asthma. So, next slide po. Now for the beta-1 stimulation. Beta-1 stimulation causes increased myocardial conductivity and increased heart rate as well as increased contractile force. So, ang isipin ulit naman natin ngayon sa beta-1 receptor is the heart contraction. Ngayon naman sa beta-2 receptor stimulation, it causes relaxation of bronchial smooth muscle with some inhibition of inflammatory mediator release and stimulation of mucociliary clearance. So, ulitin natin na ang pinaka main point ng beta-2 receptor natin is to cause relaxation of bronchial smooth muscle or bronchodilation. Now, for the bronchospasm, nasabi natin kanina na ang bronchospasm is the narrowing of bronchial airways. So, it is caused by the contraction of smooth muscle. Now, for the catecholamines naman, it is a group of similar compounds having sympathomimetic actions. They mimic the actions of epinephrine. So, mag-focus muna tayo dito sa sinasabi niyang they mimic the actions of epinephrine. So, basically, ang catecholamines natin, nabanggit niya doon na mimic. It means, ginagaya niya yung mismong actions ng epinephrine natin. So, ano nga ba yung actions ng epinephrine natin? So, epinephrine prepares the body to respond to stress or emergency situations, or pwede natin siyang sabihin na sila yung mismo nag-respond sa fight or flight situations natin. So, ano ba yung ginagawa ng epinephrine natin? Unang-una, kapag na-stimulate yung epinephrine natin, it stimulates the beta-1 stimulation. Kapag nangyari yun, kapag na-stimulate yung beta-1 stimulation natin, it increases the heart rate and contractility. Kapag naman na-stimulate yung beta-2 receptors natin, magkakause yun ng bronchodilation, and kapag naman alpha-1 receptors, it can cause vasoconstriction. Next slide po. Now, cyclic adenosine 3,5 monophosphate or CAM is a nucleotide produced by beta-2 receptor stimulation, and it affects many cells but causes relaxation of bronchial smooth muscle. So, ang isipin lang natin dito, kapag sinabi natin cyclic adenosine 3,5 monophosphate or CAM, basta pinoproduce siya ng beta-2 receptor. So, ano ba yung ginagawa ng beta-2 receptor? Di ba sinabi natin kanina na ang beta-2 receptor, ang ginagawa niya is nagkukos siya ng bronchodilation. So, yun lang mismo yung function niya to dilate for bronchodilation. Ngayon naman sa cyclic guanosine monophosphate or CGMP, it is a nucleotide producing the opposite effect of the CAM. That is, causes bronchoconstriction. So, sinabi natin kanina na kung bronchodilation yung sa CAM, ngayon naman sa CGMP, bronchoconstriction yun. Now, for the downregulation is a long-term desensitization of beta receptors to beta agonists caused by a reduction in the number of beta receptors. So basically, ang nangyayari lang mismo sa downregulation is that masyado nating ini-stimulate yung beta agonist natin. Ngayon, mararamdaman ng body natin na masyado nang madami or masyado nang parang too much na yung stimulation ng beta agonist natin. So, ang gagawin ng cell, tatanggalin niya yung onting mga beta-2 receptors sa surface mismo ng cell. But then, since fewer na lang yung matitira na beta-2 receptors, it would lead to the drugs that can't work. Parang hindi niya magagawa yung function niya in a more effective way. So, parang ganun yung mismong point ng downregulation. And then, since hindi gaanong nagawa nung medication yung mismong function niya, then magkakaroon tayo ng less bronchodilation kahit na same pa din yung dose ng drug na binigay natin. Ngayon naman sa prodrug tayo. Prodrug is the drug that exhibits its pharmacologic activity when it is converted inside the body to its active form. Basically, sa prodrug, inactive siya kapag binigay natin siya sa patient or inactive siya kapag ina-administer natin siya sa patient. But kapag na-metabolize na mismo ng body natin yung medication na yun, it becomes active. So, first, ulitin natin, kapag drug is administered, inactive pa siya. But then, kapag na-metabolize na or na-convert na natin yung drug, then magiging active na siya. Now, for the sympathomimetic, it produces the effects similar to those of the sympathetic nervous system. Again, minimimic lang niya or ginagaya niya lang yung yung effects ng sympathetic nervous system rather, or yung fight or flight situations natin kapag yun yung na-trigger. Next slide po. Now for the adrenergic bronchodilator group. It is used for the treatment of reversible airway obstruction in diseases such as asthma and COPD. These agents produce bronchodilation by stimulating beta-2 receptors on airway smooth muscle, and the differences in the rate of onset, peak effect, and duration led to a distinction in use between short-acting and long-acting agents. So, as we go through our discussion, i-differentiate natin kung ano yung mga medications that are considered as short-acting and then long-acting agents. So, next slide po. Indication for short-acting agents. Short-acting beta-2 agonists are indicated for relief of acute reversible airflow obstruction in the asthma or other obstructive airways. Ang example natin dito is yung levalbuterol, albuterol, perbuterol, and buterol. So, for the short-acting agents naman, they are termed as rescue agents in the 2007 NAPP EPR3 guidelines, and they can also be termed as relievers for the GINA as per the GINA guidelines. Next po. Now, for the indication for long-acting agents are indicated for the maintenance of bronchodilation and control of bronchospasm and nocturnal symptoms in asthma or other obstructive diseases. For the long-acting agents, we have the examples salmeterol, arformoterol, and formoterol, which kumuha kami ng mismong mnemonics niya, which is SAF. SAF is considered as controllers. The slow time to peak effect makes a long-acting agents for aporescue drugs. So in asthma, a long-acting bronchodilator is usually combined with anti-inflammatory medications for control of airway inflammation and bronchospasm. So ano ba yung reason kung bakit minimix natin or kino-combine natin yung anti-inflammatory medication dun sa long-acting bronchodilator? So, i-break down muna natin. Yung long-acting bronchodilator kasi natin, it keeps the airway open or relaxed longer. Kapag naman yung anti-inflammatory medications naman natin, from the word itself, anti-inflammatory, it reduces chronic airway inflammation. So basically, it reduces airway inflammation. So, kapag ipagsasama natin or i-combine natin yung dalawang medications na yun, they are better asthma control. So, they prevent asthma attacks, they improve lung function, and reduces the symptoms. Formoterol acts quickly like albuterol, but lasts longer, making it better for maintenance than for rescue use. Next slide po. For the indication for racemic epinephrine naman, racemic epinephrine is often used either as an inhaled aerosol or by direct inhalation for its strong alpha-adrenergic vasoconstricting effect to reduce airway swelling after extubation or during epiglottitis, croup, or bronchiolitis, or to control airway bleeding during endoscopy. So, para mas concise lang yung isipin natin dito sa indications for racemic epinephrine, ang tatandaan lang natin, it is an inhaled alpha-adrenergic vasoconstrictor used to reduce airway swelling and then yung airway bleeding natin. So, next slide po. So, here are the different inhaled adrenergic bronchodilator agents that is currently available in the United States. So, I suggest po na basahin niyo po mismo sa RAW where there is an even clear explanation for this po. Next slide po. Now, para mas madali po natin ma-memorize kung ano yung mga ultra short-acting agents and then short-acting sa long-acting, meron po kami ginawang mismong mnemonics. For the ultra short-acting agents, we have epinephrine and racemic epinephrine that has a duration of less than 3 hours. For the short-acting naman, we have the mnemonics PALM, which stands for perbuterol, albuterol, levalbuterol, and metaproterenol, which has a duration of 4 to 6 hours. For the long-acting agents naman, we have the mnemonic SAF, which stands for salmeterol, arformoterol, and formoterol, which have a duration of 12 hours. Next slide po. Catecholamine. Catecholamines is a chemical structure consisting of an aromatic catechol nucleus and a dialiphatic amine side chain. It is a sympathomimetic bronchodilators or all either catecholamines or derivative of catecholamine. So yung sinabi natin kanina na yung catecholamines natin, they mimic the actions of epinephrine since it prepares the body to respond to stress and emergency situations or yung tinatawag natin fight or flight. It can cause, yung sinabihan kanina na sa fight or flight situation siya nag-activate and it cause tachycardia, elevated blood pressure, smooth muscle relaxation of bronchioles and skeletal muscle, blood vessels, glycogenolysis, skeletal muscle tremor, and central nervous system stimulation. Next slide po. Now, adrenergic bronchodilators as stereoisomer. Adrenergic bronchodilators can exist in two different spatial arrangements producing isomers. Ngayon, yung sinasabi niyang dalawang different spatial arrangements producing isomers, we have the dextrorotatory and levorotatory. And then later on, or mamaya-maya lang, i-explain pa natin or i-expound pa natin kung ano yung pinagkaiba ng dalawa. So the rotation around the beta carbon on the ethylamine side chain of the basic molecular structures in figure 6-1 produces two non-superimposable mirror images termed as enantiomers or simply isomers. Ngayon, nabanggit sa first bullet yung isomers. Ano ba yung isomers natin? Paano ba natin siya i-differentiate mula dun sa enantiomers dun sa second bullet? Kapag sinabi natin isomers is a molecules that has the same chemical formula but has a different arrangement of atoms. Same daw sila ng chemical properties pero magkakaiba sila ng arrangement ng atoms. Kapag naman sinabi natin enantiomers, they have the same chemical and physical characteristics but they have a different physiological effect. So kung makikita nyo dito, yung sa left side natin, yung dextrorotatory natin, and then yung levorotatory natin na epinephrines, makita nyo as isomers na kahit na meron silang same chemical components or same chemical properties, makita nyo na yung arrangement nila is different from each other. Kapag naman sinabi naman natin enantiomers, yun nga, parehas sila ng chemical properties and physical properties, but then they have a different physiological effect. And then, may expound pa natin din sa next slide. Next slide po. The two mirror images of the isomers rotate light in opposite directions, and this is the basis for designating them as dextrorotatory or levorotatory. So kung makita nyo sa dextrorotatory natin na it rotates slightly to the right or clockwise yung sa dextrorotatory natin. And then kapag naman sa levorotatory, it rotates lightly on the left, which means counterclockwise. Kung mapapansin nyo sa mismong image natin na yung dextrorotatory natin rotates from clockwise and then yung levorotatory natin nag-rotate siya counterclockwise. So using their actual spatial configuration, the levoisomer and dextroisomer are referred to as R isomer or for rectus right and S isomer for sinister left respectively. Next slide po. So now let's proceed to epinephrine. In epinephrine, it is a potent catecholamine bronchodilator that stimulates alpha and beta receptors. Because the epinephrine lacks beta-2 receptor specificity, there is a high prevalence of side effects such as tachycardia, blood pressure increase, tremor, headache, and insomnia. So, sa epinephrine kasi, it stimulates both alpha and beta receptors, pero nagkukulang siya sa beta-2 receptors specificity. So since onti lang yung beta-2 receptor specificity natin na nagkukos ng bronchodilation, then we expect na there is a high prevalence nga ng tachycardia, ng blood pressure increase, tremor, and headache and insomnia since ang pinakamaraming receptor sa epinephrines natin is the beta-1 receptor which causes the opposite effects of the beta-2 receptors. Epinephrine occurs naturally in the adrenal medulla and has a rapid onset but a short duration because of metabolism by catechol o methyltransferase or enzyme natin COMT. So it has been administered both by inhalation and by subcutaneous injection to treat patients with asthma exacerbation. So next slide po. It is also used as a cardiac stimulant based on its strong beta-1 effects. So sinabi natin kanina na ang epinephrine natin lacks the beta-1 receptors, and then mas madami siyang beta-1 receptors, kaya yun nag-result into a strong beta-1 effects, which causes the increase in cardiovascular risk, limiting its routine use kapag tumataas yung heart rate natin, yung blood pressure, and then yung tremors, yung anxiety, yung headache, and then yung insomnia. So epinephrine is also self-administered intramuscular doses of 0.3 milligrams and 0.15 are marketed to control systemic hypersensitivity or anaphylactic reactions. So, ano ba itong anaphylaxis? Bakit nga ba tinitreat yun ng epinephrine natin? Ang anaphylaxis kasi, it is a severe and potentially life-threatening allergic reaction. So, bakit nga ba siya life-threatening? Kasi nga, kung mag-base tayo sa mismong pharmacokinetics ng epinephrine natin, or sa may anaphylaxis, it works this drug is more useful pala for the management of acute asthma rather than for daily maintenance therapy because of its pharmacokinetics and side effect profile. So, pag-usapan natin kung bakit nga ba maganda yung epinephrine natin for maintenance therapy in terms of its pharmacokinetics. Kasi, sa pharmacokinetics ng epinephrine natin, it works quickly, minutes to be precise, to open the airways. And then, yung short duration kasi nun, it lasts only for about 1 to 2 hours. And then, the side effects profile naman, it increases cardiovascular risk, limiting its use, kaya siya nagkakos ng increase in heart rate, increase in blood pressure, tremors, anxiety, headache, and insomnia. Next slide po. Now we proceed to the keyhole theory of beta-2 specificity. The theory that explains the shift from alpha activity to beta-2 specificity has been termed as keyhole theory of sympathomimetic receptors. So basically, ang sinasabi lang dito sa theory na to is that the bigger the side chain will always result to a more beta-2 selectivity and from that, mag-result yun into a better airway effects. So, the larger the side chain attachment to the catechol base, the greater the beta-2 specificity. If the catecholamine structural pattern is seen as a key-like shape, then the larger the key or the side chain, the more the beta-2 specific drop. For example, ang pinaka-key term lang na isipin natin sa theory na to is that yung side chain, kapag mas malaki yung side chain, mas mag-fit siya sa beta-2 receptor. And from then, kapag mas mag-fit siya sa beta-2 receptor, then mas magkakaroon tayo ng beta-2 selectivity. And from that, since known yung beta-2 receptors natin for causing bronchodilation, then we expect na magkakaroon ng bronchodilation and then mas bababa yung heart stimulation natin or hindi gaanong mag-contract yung heart natin. Ngayon naman, ano naman mangyayari dun sa small side chain? So, in the opposite lang ng larger side chain, kapag small yung side chain natin, mas mababa ngayon yung beta-2 selectivity natin. Tapos, mas matitrigger niya yung beta-1 receptor. Beta-1 receptor, which can cause cardiovascular side effects. Tataas yung heart rate mo, tataas yung BP mo, tataas yung magkakaroon ka ng anxiety, yung insomnia, and etc. Next slide po. Now for the metabolism of catecholamines. Despite the increase in beta-2 specificity with increased side chain bulk, all the previously mentioned catecholamines are rapidly inactivated by the cytoplasmic enzyme COMT. COMT is found in the liver and kidneys and throughout the rest of the body. So the resulting compound, metanephrine, is inactive on adrenergic receptors. Ano ba itong metanephrine natin? Ang metanephrine kasi natin is the inactive form ng epinephrine natin. Yun yung kapag the epinephrine kasi kapag napunta siya sa liver natin, it will be inactivated by the COMT. So kapag na-inactivate siya ng COMT, it will result to metanephrine. Yung metanephrine natin, inactive daw siya sa adrenergic receptors. So since inactive siya sa adrenergic receptors, then it will cause no bronchodilation. Wala siyang kinokos ng bronchodilation sa adrenergic receptors natin. So, because the action of COMT enzyme on circulating catecholamines is very efficient, the duration of actions of this drug is severely limited with a range of 1.5 hours to at most at 3 hours. So, since masyadong nag-work or masyadong malakas yung COMT sa mismong site niya, parang nalilimit niya lang yung duration ng drug na yun into 1.5 hours to at most at 3 hours. Next slide ko. Now, it is also unsuitable for oral administration. So, bakit nga ba sila unsuitable for oral administration? Kasi nga, since they are rapidly inactivated by the COMT enzyme sa liver natin, then we can expect na wala silang therapeutic effect dun sa mismong body natin. So, ayun na, nasabi sa second bullet na it has no effect when taken by mouth, limiting their route of administration to inhalation or injection lang. Catecholamines are also readily inactivated to inert adenochromes by heat, light, or air. For this reason, the racemic epinephrine is stored in an amber-colored bottle or a foil-protected wrapper. So, mag-focus po tayo sa third bullet. Catecholamines are readily inactivated to inert adenochromes by heat, light, or air. Ang sinasabi lang dyan, ano ba yung adenochromes? Yung adenochromes natin is inactive compound siya kapag yung catecholamines natin is na-oxidize via heat, light, or air. So, since ayaw natin mangyari yun, ini-store natin yung catecholamines or yung epinephrine natin din sa amber-colored bottle or a well-protected wrapper. other resourcinal agents. For the first bullet, drug researchers sought to modify the catechol nucleus which is so vulnerable to inactivation by the COMT. So bakit nga ba ginawa ng mga researchers yun? Kasi nga, meron po tayong limited duration ng catecholamines since inactivate siya ng enzyme COMT natin. So, since unsuitable siya sa vulnerable siya sa inactivation ng COMT, it is also unsuitable para sa maintenance therapy ng bronchospastic airways natin. So, metaproterenol has significantly longer duration of action to 4 to 6 hours compared with the short-acting catecholamine bronchodilators. Metaproterenol can be taken orally because it resists inactivation by sulfatase enzymes in the gastrointestinal tract and the liver, and it's slower to reach a peak effect, which is 30 than the epinephrine. So, unlike other catecholamines, the metaproterenol parang mas matagal yung duration niya as stated in the second bullet. So yun po. Next slide. Ligenin agents is a different modification of catechol nucleus at the carbon-3 site resulted in saligenin albuterol referred to as salbutamol in Europe. It has a beta-2 preferential effect, which is effective via oral administration and has a duration of up to 6 hours with a peak effect in 30 to 60 minutes. So, ang salbutamol kasi natin, it has a beta-2 preferential effect. So since beta-2 preferential effect yung meron sa kanya, then we expect na bronchodilation and relaxation of airways yung magiging cause niya. Next slide po. Pyrbuterol is another non-catecholamine adrenergic agent currently available as pyrbuterol acetate in an MDI formulation or meter-dose inhaler formulation with a breath-actuated inhaler device. The strength of pyrbuterol is 0.2 milligrams per puff and the usual dose is 2 puffs. For the onset ng activity by aerosol is 5 to 8 minutes for the peak effect, 30 minutes, and for the duration of action, we have approximately 5 hours. Next slide po. So, in addition sa information about yung previous slide po, meron pa atang slide na hindi nakuha. Okay, next slide na lang. We now proceed to prodrug or bilalterol. Sinabi natin kanina na kapag sinabi natin prodrug is inactive when we administer it to patient. But when na-convert na siya into its active form, then maging active na siya and then mas magagawa niya na yung function niya. So, it must be converted in the body to activate the drug. It consists of 2 toluene ester groups on the aromatic ring at the carbon-3 site and carbon-4 positions. Bilalterol is administered as an inhalation solution, and the active form, holterol, is a catecholamine and is inactivated by the COMT similar to any other catecholamine. So guys, dito kayo sa bilalterol, it is, kung makikita nyo, yung mismong bilalterol kasi natin, hindi siya active. Inactive form siya. kailangan muna niyang uh, ma, kailangan muna niyang ma-metabolize for it to do its work. Magiging collateral na siya, and then dun niya mas mabibigay yung function niya kapag na-activate na siya, since pro-drug yung bilateral natin. Next slide po. In animal studies, bilateral is given orally or intravenously, selectively distributed to the lungs, and in humans, inhalation is the preferred way to treat the lungs directly. Bilateral is converted to collateral more quickly in the lungs than in other tissues, resulting in a targeted effect and a higher concentration in the lungs. And then, ngayon, bakit nga ba sa humans, bakit inhalation ba yung preferred way to treat lungs directly? Kasi nga, minimize natin or ina-avoid natin na karoon ng inhalation lang mismo para targeted sa lungs yung pagbibigay natin ng medication. Collateral is excreted in urine and feces as free conjugated collateral and as a metabolite of collateral. Next slide po. Levalbuterol, the R isomer of albuterol. Levalbuterol is the pure R isomer of racemic albuterol. Although the S isomer is physiologically inactive on adrenergic receptor, there is an accumulating evidence that the S isomer is not completely inactive. So, ang sinasabi kasi nila natin na yung S isomer natin is physiologically inactive or wala daw siyang ginagawa, wala daw siyang effect sa body natin. But in recent studies, parang nalaman nila na may effect somehow yung S isomer natin. Ano ba yung mismong kinocontribute niya? It contributes airway inflammation. And S isomer is more slowly metabolized than R isomer. Next slide po. Levalbuterol is available as an HFA or hydrofluoroalkane inhaler and as a nebulizer solution in 0.31, 0.63, and 1.25 milligram unit doses. It also comes as a concentrated solution of 1.25 milligrams and 0.5 milliliters. So, in a study by Nelson and colleagues, the 0.63 milligrams dose was found to have a similar onset and duration of action as a 2.5 dose of racemic albuterol. So, dun sa study na yun, mas nalaman nila na yung effectiveness daw ng 0.63 milligrams of levalbuterol is the same as the 2.5 milligrams of racemic albuterol. For the side effects naman kasi, the single isomer formation cause fewer side effects such as tremor and changes in heart rate. So, for the fifth bullet, the 1.25 milligrams dose of levalbuterol produced a higher peak improvement in the FEV1 or the forced expiratory volume 1 and lasted about 8 hours compared with racemic albuterol. So, dun sa 1.25 milligrams of albuterol, it has a higher peak of FEV1 improvement and it has a longer duration of 8 hours. So, ano ba yung FEV1 improvement na sinasabi natin dito? It is when the lungs open wider at the maximum effect rather. The next slides will be discussed by Christian Guillermo.
So, am I loud and clear, everyone? Great. So, good day everyone. I am Christian Guillermo and I will be presenting the next slide and I hope you learn something from me. So, as we all know, as discussed from the past topic of Sixto, we all know that short-acting inhalers or SAVAs, like the standard albuterol, are like a quick burst of energy. They work fast, but they leave the body in 4 to 6 hours. This often leaves asthma patients unprotected in the middle of the night, leading to morning dipping of lung function. So, dito na pumapasok yung long-acting beta-adrenergic agents natin or LABAs. So, the transition in respiratory care has moved from non-specific to short-acting beta agents like your epinephrine to beta-specific agents. So, what is the use of it? So, for less frequent dosing twice daily and improved nocturnal protection for asthmatic and COPD patients. And typically provides bronchodilation for 12 hours or longer. So, bakit nga ba siya naglalast ng 12 hours or longer compared sa SABAS na 3 or 4 hours lang? So, why do LABAS last so long? It is because they are life-of-healing or fat-loving. Instead of staying in the watery space outside the cell, they actually dissolve into the cell's oily membrane and hide there, and creating a depot of storage unit that slowly releases the drug throughout the day. So examples of these agents are extended release albuterol and newer drugs like your salmeterol, formoterol, and arformoterol. So next slide please. So as you can see in this picture, think of labas as the long distance runners, your marathoners of the respiratory world. They provide a steady 12 hours safety net that allows patient to sleep through the night without waking up gasping for air. Next slide please. So now we have extended release oral albuterol or Vospire ER. So its delivery is 4 milligrams or 8 milligrams oral tablets. And it uses a two-step coating and is osmotic gradient. So in this Vospire ER, instead of the drug hitting all at once, the tablet is designed like a time release capsule that mimics taking two separate doses several hours apart. So it uses a two-step coating, 2 milligram in the coating for immediate release, and 2 milligram in the core for release through a laser drilled pinhole over several hours. So let's start with 2 milligram in the coating. So this 2 milligram in the coating, it is the outer layer that dissolves immediately to give you a quick 2 milligram dose, while the core holds the rest for later. So, dito sa core, dito na pumapasok yung osmotic gradient system natin. So, the osmotic gradient, think of this like a tiny pump. The pill actually draws in water inside the drug, which dissolves the medicine and pushes it out of a laser drilled pinhole, like in this picture, at a slow and steady rate. And it mimics 2 doses of standard albuterol and extending activity to 8 to 12 hours. Next slide, please. So now we have salmeterol or your Cerevent. So its formulation is in the form of dry powdered inhaler or discus and a raised mixture where the R isomer is active. So its pharmacodynamics or what it does to the body, its onset is slower, that has 14 to 22 minutes, and peak is 3 to 5 hours. And its mechanism, it is high lipophilicity, or it is fat solubility. A long molecular tail anchors the drug to an exocyte in the cell membrane, allowing the active head to continually stimulate the brain beta receptor. So we all know most inhalers float around the cell, but salmeterol has a long greasy tail. This acts like an anchor, as you can see in the picture, like an anchor, burying itself into the specific spot on the cell called an exocyte. So while the tail's anchored, while the tail stays anchored, the active head of the molecule can flip in and out of the receptor, repeatedly activating it over and over again for almost 12 hours. So, clinical note, due to lower intrinsic efficacy, it may be safer for patients with cardiovascular disease. So, as we all know, because it has lower intrinsic efficacy, meaning it is a gentler option for the heart. This makes it a preferred choice for patients who might have cardiovascular concerns but still need a long-term lung protection. Next slide, please. So let's go on with formoterol, also known as Foradil or Performist. So its formulation is available as dry powdered inhaler, also known as aerosolizer, or liquid nebulization or Performist. What it does to the body, its onset is very fast, within 2 to 3 minutes, similar to short-acting albuterol. Compared sa salmeterol natin na 14 to 22 minutes na slower, this formoterol is very fast, within 2 to 3 minutes siya. And its peak is approximately 2 hours. Its mechanism, also highly lipophilic, remaining in the lipid bilayer to provide a 12-hour effect. So unlike salmeterol, which also anchors to a specific spot, formoterol is like a SpongeBob. It soaks like into the fatty layer of the cell membrane, the lipid, or also known as the lipid bilayer, and creates a depot or storage site that slowly leaks medicine out over time. It starts working almost instantly, just like a rescue inhaler, but it stays in the system for a full 12 hours. This makes it a powerful tool for maintenance, as it is actually more effective at relaxing airway muscles than even albuterol or salmeterol. And it shows higher maximal efficacy in relaxing airway smooth muscles than both albuterol and the salmeterol. Next slide, please. And lastly, we have the R-formoterol or Brovana. Its formulation is single isomer or formoterol, and indication of use, it is for maintenance treatment of COPD. So, while many other drugs comes as powders or sprays, Brovana is designed specifically for nebulization. This makes it a go-to choice for COPD patients who might have trouble coordinate tro- who might have trouble coordinate using a handheld inhaler but need that long-term twice daily protection. So, delivery 50 micrograms via 2 milliliter unit dose vials for nebulization only. Take note guys, for nebulization only, and administered twice daily. So, fun fact about this alpha-formoterol or Brovana, scientists created alpha-formoterol by isolating just the active part of the formoterol molecule, and you get a more concentrated and for specific effect. Next slide, please. So it is the pictures of the salmeterol, formoterol, and alpha-formoterol. Next slide, please. Oh, so to summary it, the long duration of action in labas is primarily due to lipophilicity. So remember guys, the long duration of action in lavas is primarily due to its lipophilicity or fat solubility and unique drug receptor interaction. So bahala na kayo magbasa guys. Next slide please. So its clinical application and safety profiles of lavas. Indication for use for asthma and COPD. For asthma, use as a three-step care for patients whose symptoms are not controlled by regular low-dose inhaled corticosteroid. So for COPD naman, indicated for patients requiring daily bronchodilator therapy for reversible airway obstruction. So, adding alaba can improve lung function and decrease symptoms without needing to increase the steroid dose. Next slide, please. So, laba versus saba. Labas are not for rescue use. Remember, labas are not for rescue use. Their high lipophilicity and long duration head lead to drug accumulation and potential toxicity if administered repeatedly for acute symptoms. Patients must always have a SABA, example albuterol, available for breakthrough symptoms between scheduled LABA doses. So, salmeterol, it is slow and long acting. Formoterol, fast and long acting. Always remember that, guys. Salmeterol, slow and long acting. Formoterol, it is fast and long acting. Next slide, please. Now we have combination therapy. Combining alaba with a corticosteroid, for example, Adrenergic, it is a combination of salmeterol and fluticasone. It provides superior control compared to using either drug alone. Labas provide a higher baseline of lung function. Taking a laba twice daily provides a greater total area of bronchodilation than taking a saba 4 times daily. So, laba is great at relaxing muscles around the airways. It doesn't treat the underlying swelling by combining alaba. By combining alaba with a corticosteroid, we are attacking the problem from the two different angles at once. First, we open the pipes, and second, we calm the fire inside them. So, we can say that that less is more in this scenario because taking one combination inhaler a day is actually more effective and much easier for the patient to remember than taking a rescue inhaler 4 times a day. Next slide, please. So let's go on with the safety concerns and analysis. So studies of Salpeter and Nelson indicated an increased risk of asthma-related hospitalization and deaths, particularly noted in African American population. It is unclear if these risks were due to the drug itself or variables like asthma severity, lack of patient adherence, or the dangerous practice of using a LABA without a steroid. Next slide, please. So, FDA safety mandates. So, to mitigate the risk, after this study, to mitigate the risk, they come up with a solution to mitigate the risk. So after they study, they come up with a solution to mitigate the risk. The FDA strictly regulates LABA used in asthma. First, to ne- to never to never monotherapy must always be used with a controller or ICS or your inhaled corticosteroid. Number two, It is not for mild asthma and should not be used if the patient is already controlled on low to medium dose steroids. Third, short-term use. Once asthma is controlled, the lava should ideally be discontinued. Remember, the lava should ideally be discontinued if the asthma is controlled and the patient maintained on a controller alone. Number 4, pediatric safety. Children should only use lavas via combination products to ensure they never skip their corticosteroid dose. Next slide, please. So, let's go on with the mode of action of adrenergic receptor activation. So, receptor types and clinical effects. Adrenergic bronchodilators interact with three primary receptors, naming A alpha receptor, B1 receptor or the beta 1 receptor, and the beta 2 receptor, and each producing a specific physiological response. Let's start with the alpha receptor. Its key clinical effect is vasoconstriction, and application is for upper airway decongestion. So, alpha receptor, the decongestant. Think of these as the constrictors. When these are activated, they tighten up leaky blood vessels. This is why they are so good for clearing up a stuffy nose. They shrink the swelling in your nasal passages. Let's Next is the beta 2 receptor. Its effect is for cardiac stimulation, increased heart rate, and contractile force. These are primarily found in the heart. The beta 2 receptor, beta 1 receptor are primarily found in the heart. Activating them is like stepping on the gas pedal of a car. The heart beats faster and pumps with more force. This is usually a side effect we try to avoid when treating the lungs. Now, beta 2 receptor effect bronchodilation, and 4 is smooth muscle relaxation and mucociliary clearance. And this as for us artists, this is our main target. When a drug hits this receptor, this beta 2 receptor, it tells the tight muscles around your airways to relax and let's go. Causes bronchodilation. It also helps the lungs clear out mucus, making it easier for patient to breathe. So always remember that alpha receptor is for vasoconstriction, beta 1 receptor is for cardiac stimulation, beta 2 receptor for bronchodilation. Next slide, please. So, the beta 2 signaling pathway or bronchodilation. This is the process of relaxing airway smooth muscle follows a specific G protein link sequence. First step, the beta agonist binds to a receptor called a peptide chain traversing the cell membrane 7 times within the barrel formed by its transmembrane loops. Second step, after the binding, this binding triggers a conformational change that activates the stimulatory G protein or the GS. Then, after it activates the stimulatory G protein, the A subunits of the GS protein dissociates and activates the adenyl cyclase, or also known as a membrane-bound enzyme. So, after niya, so next slide please. So, after niya ma-activate yung adenyl cyclase, yung adenyl cyclase naman, it will convert into ATP into cyclic adenosine 3,5 monophosphate or your CAMP. And and it leads to muscle relaxation. Increased CAMP levels lead to inactivation of the myosin light chain kinase, which is the enzyme that triggers contraction. Ini-inactivate niya daw yung enzyme kinase. So, reduction of intracellular levels. So, to summarize it, stimulation of the beta-2 receptor by an adrenergic agonist triggers a conformational change that activates the stimulatory G proteins. First, it activates the stimulatory G protein. Then this causes the alpha subunit of the G protein to dissociate and link the effector enzyme adenyl cyclase. After niya ma-activate, this enzyme increases the synthesis of the second messenger, which is the cyclic adenosine 3,5 monophosphate or your CAMP. The rise in CAMP leads to smooth muscle relaxation by inactivating the myosin light chain kinase. So, after niya ma-inactivate yung kinase natin, which is the myosin light chain kinase, that that the enzyme that normally starts the contraction process, and by decreasing intracellular calcium levels. And this process results in the opening of the airways and improved mucociliary clearance. So always remember that beta 2 is for bronchodilation. Next slide, please. Next slide, please. So the role of alpha 2 receptor stimulation. While the beta receptors stimulate action, alpha 2 receptors typically act as a brake. It inhibitory function niya, activation of alpha 2 receptors triggers the inhibitory G protein or the GI. This inhibits adenyl cyclase, thereby lowering CAMP synthesis. It often serves as an autoregulatory feedback mechanism to inhibit further neurotransmitter release. So compared sa beta 2 bronchodilation, the alpha 2 receptor naman, it inhibits further neurotransmitter release. Next slide, please. And for alpha 1 receptor activation naman, vasoconstriction. While beta 2 receptor relax muscles, alpha 1 receptors cause contraction of vascular smooth muscle, causing vasoconstriction, which help reduce mucosal edema or decongestion. So the signaling cascade of the alpha 1 receptor, its binding, an agonist or for example, epinephrine, bind to the alpha 1 receptor. This leads to the activation of the GQ protein. Take note guys, GQ protein. And effector, the A subunit activates phospholipase C or the PLC. And we also have here second messengers. The PLC converts membrane lipid into inositol 1,4,5 triphosphate or the IP3, which stimulates the release of intracellular calcium. And diacylglycerol or your DIG activates protein kinase C, increased and which leads to increased cytoplasmic calcium triggers vascular smooth muscle contraction. So, to summarize it, so yung binding ng for example, epinephrine nagbind siya sa A1 receptor, it activates the GQ protein. Then this activation leads to effector enzyme phospholipase kinase to convert membrane lipids into inositol 1,4,5 triphosphate or your IP3 and diacylglycerol or your DAG. Then IP3 then stimulates the release of internal calcium, stores into the cell's cytoplasm, which acts as a primary trigger for vascular muscle contraction. So always remember, guys, that that the beta 2 is for bronchodilation, alpha 2 is for inhibition of neurotransmitter release, and the alpha 1 is for smooth muscle contraction. Next slide, please. Next slide, please. So here we have the G protein systems. We have receptors, beta 1, alpha 2, and the alpha 1. The G protein for beta 2 is GS, and alpha 2 G1, and alpha 1 is GQ. And its effector is for beta 1 adenyl cyclase, for alpha 2 adenyl cyclase, which cause inhibitions, and alpha 1 phospholipase that causes vasoconstriction. And for second messenger, for beta 1, it has a increased CAMP. For alpha 2, decreased CAMP. And alpha 1 is, its second messenger is IP3 and PAG. So the result for beta 1, so always remember this, guys. For beta 1 is smooth muscle relaxation or bronchodilation. Alpha 2 is inhibition of neurotransmitter release, and alpha 1 is for vasoconstriction. Next slide, please. Now we have salmeterol, formoterol, and alformoterol mechanism of action. First, we have salmeterol. It consists of a hydrophilic head, a long lipophilic, non-polar tail, and unlike short-acting beta drugs that approach from the aqueous space, salmeterol diffuses into phospholipid bilayer and approaches the receptor laterally. The lipophilic tail anchors into a specific hydrophobic region of the receptor called exosite. Because the tail is anchored, the active head can now continually attach or detach from and attach to other receptor. Take note, if a beta blocker is applied and then removed, salmeterol's effect returned immediately because the drug was never washed away. It remained anchored. Next slide, please. For formoterol and arformoterol, these drugs are moderately lipophilic and hide within the cell membrane's lipid layer, which acts as a depot or storage for slow release. They can approach the receptor from both the aqueous phase, which allows for rapid onset, and the lipid phase, allowing for long duration. So, in comparison, salmeterol is more lipophilic than formoterol, making it less likely to be washed away from the tissues, but is slower to start. And that's all for my part, guys. Thank you. The next slide will be presented by Mariel.
Good day, everyone. So now let's talk about the routes of administration. So basically, ang root ruta or route of administration ng B agonist is inhalation. Pwede siyang inhalation, pwede siyang oral, and parental. So, ang una nating i-discuss is yung inhalation. So, ang sabi dito na all beta-adrenergic bronchodilators in the US are available for inhalation via MDI nebulizer or DPI. Kasi mas preferred daw po ang inhalation because dinadirect po yung drug, it directly delivers the drug through the lungs na nagpo-produce or nagko-cause ng rapid effects kahit na small doses lang po siya. At saka po kasi nare-reduce din po kasi yung side effect pag ang ginagamit is via inhalation. Although aerosol use during acute airway obstruction has been questioned, studies show no major difference compared to parenteral use in severe asthma. Sabi dito na some challenges include proper inhaler technique and time needed for nebulization, but this can be managed with spacer or alternative devices. Then next is meron tayong tinatawag na continuous nebulization, which is ginagamit siya for mga severe asthma po to prevent respiratory failure. But may study po kasi si Lin na nagsasabi na faster po ang improvement gamit ang continuous nebulizer in patient with forced expiratory volume. Less than 50% ang of predicted. Then, ang sabi naman po sa study ni Shrestha na compared sa high dose po and low dose ng albuterol with both continuous and intermittent nebulizer, yung FEV po niya is improved more with continuous than yung sinasabi nilang intermittent nebulizer. Na kahit na low dose po ang nilagay and was as effective as same lang po ang effect niya sa low dose and higher dose sa continuous administration po. This and other results suggest that there is a benefit to continuous nebulization in severe airflow obstruction, but a dose less than 10 to 15 milligram per hour may be effective with less toxicity. Then, meron tayong delivery methods, which is, meron tayong delivery method ng continuous nebulization po. Meron tayong yung measured refilling of small volume nebulizer. Meron tayong volumetric infusion pump with small volume nebulizer. Then, meron tayong large reservoir nebulizer, such as yung heart or hope nebulizer po. Then, meron din po yung toxicity and monitoring. Kasi kailangan din po nating i-monitor ang toxicity ng gamot at nung ginagamit nating pang administer po. So, sabi dito ng continuous nebulization daw ng beta agonist is hindi po siya standard therapy. And the patients receiving this treatment have serious airflow obstruction. Potential complications include cardiac arrhythmias, hypokalemia, and hyperglycemia. Tapos sabi na unifocal premature ventricular contractions were reported in patient 5 Portnoy and of course associates. Significant tremor may also occur. Yung tremor po is mas parang i-discuss po natin siya later pa po. Mas i-discuss po natin siya deeply sa mga side effects po mamaya. Then, sabi din dito na kailangan po ng close monitoring sa patients na na nagre-receive ng continuous ng beta agonist kasi yun nga po kasi nga po meron pong potential na complications sa potential po na side effects na mangyayari sa patients pag yun po nasobrahan. Then, ayan. Nandito naman po tayo sa oral route. The oral route of beta agonist is easy to administer and allows accurate dosing. But, it is not preferred clinically compared to inhalation kasi oral B agonists have slower onset po. Hindi po katulad ng inhalation na fast po ang ay rapid onset. Ito po kasi sa oral, about 1.5 hours lang po siya. Then, ang peak niya po is 1 to 2 hours and also naglalast ng 3 to 6 hours. Yan. And kailangan din po kasi ng large doses dito na nag-i-increase din ng frequency niya and syempre severity of side effects din po. Katulad po ng catecholamines na ineffective orally and also non-catecholamine bronchodilators may lose beta 2 selective due to first pass liver metabolism. Yan. Kasi syempre po, pag oral, may tawag dyan, meron yung first pass effect na sinasabi. Then, extended release oral albuterol provides over 8 hours of action, but long-acting inhaled beta agonists like salmeterol and formoterol has about 12 hours and are better for preventing nocturnal asthma and monitoring symptoms. Morning symptoms, sorry. Then, meron tayong parenteral route, which is yung mga beta-adrenergic bronchodilators can be given subcutaneously or intravenously. Sa IV po to, yung parang tinutusok na po siya directly sa mga nerves po natin. Ito po ay ginagamit sa emergency treatment ng acute asthma. Yan. Subcutaneous epinephrine and terbutaline are commonly used with no significant difference in effectiveness between them or compared to aerosolized therapy. Although IV administration was thought to improve drug delivery during severe obstruction, aerosols are still effective even in obstructed airways. So basically, ginagamit lang po ang parenteral route pag emergency na po siya. Sa emergency lang po siya ginagamit. Sabi dito na intravenous therapy is considered the last resort due to the risks such as tachycardia and serious arrhythmias, especially with isoproterenol, which should be avoided in acute asthma in favor of more beta-2 selective agents. IV treatment requires close monitoring. The overall benefit of IV albuterol compared to oral, inhaled, or subcutaneous routes remain uncertain. Hindi pa rin po sure yung mga overall benefit nila kahit ginagamit po. Kasi may mga possibilities pa rin po talaga na may mag-fail po sa kanila. Then, nandito na po tayo sa may side effects. Yan. Makikita dito ang side effects seen with beta agonists. Meron tayong tremor, which is yung muscle tremor po siya. Annoying effect of muscle tremor with B agonist due to stimulation of B2 receptors in skeletal system. Yan po. po ang tolerance sa side effect of tremor usually develops after days to weeks with the oral route, and patients should be reassured of this when beginning to use these drugs. Yeah. For more, I suggest po na basahin yung book po talaga. But, as you can see po, nandito po yung possible or adverse side effects po. Yan. Ng B-agonist use. Ngayon, meron tayong sa cardiac effect. Sabi dito na older adrenergic bronchodilators with strong beta-1 and alpha effect were risky in heart failure because they cause tachycardia and increase oxygen demand, reducing, syempre, ang cardiac efficiency. Ang older adrenergic po yan. Pero pag newer naman po, reduce cardiac stimulation but may still cause mild tachycardia. Kasi po, siguro dahil din po siguro sa pag-evolve, kaya older adrenergic is risky. Siyempre, the new ones may still cause but lesser na lang din po siya. Drugs like albuterol and terbutaline can improve cardiac performance by reducing afterload and increasing contractility without raising oxygen demand. A pulse increase of more than 20% from baseline after bronchodilator therapy is considered excessive and may require stopping treatment and referral. Yan po. Pag lumagpas na po ng 20% or nag-increase ng 20% ng above 20% yung sa baseline ng bronchodilator, delikado na po yun. Kailangan na pong parang i-monitor o i-stop yung treatment po. Yan. Para less din po yung cardiac effect, yung kumbaga heart failure na po yan eh. Next, we have the tolerance to bronchodilators effects. Sabi dito na drug tolerance occurs when repeated use reduces a drug effectiveness. Pag lagi mong ginagamit yung gamot, parang over the time, parang mawawalan na siya ng effect kasi lagi mo siyang ginagamit o lagi mo siyang iniinom. Yan. With beta-agonist bronchodilators such as albuterol, isoproterenol, and terbutaline, na parehas na short-term and long-term cessation of B receptor can occur. Sa short-term desensitization daw, lang siya, minutes of exposure, occurs within minutes of exposure, caused by uncoupling of the beta receptor from adenylyl cyclase, reducing yung CAMP production. Ang kanya po mechanism, B agonist stimulates receptor which is nag-increase ng CAMP na nag-activate po nung protein kinase na A. Ang tawag ay BARC. Then, meron tayong beta-ARC phosphorylates the receptor. Then, beta-arrestin binds to the receptor which prevents na yung interaction with G's protein. Now, this blocks signaling and reduces bronchodilator response. Yan. Then, sabi dito na when the drug is removed, the receptor can return to normal function. Kumbaga, pag nilagay mo yung drug, magkakaroon ng changes. Pero pag tinanggal mo naman or wala na yung drug, babalik na sa dati yung receptor, sa normal function yung receptor. Then, meron tayong long-term desensitization, which is ang tinatawag nilang down-regulation. Ito yung caused by a decrease in the number of beta receptors on airway smooth muscle cells. Ito yung repeated exposure to norepinephrine or albuterol na nare-reduce niya yung receptors by reduce numbers by 50% in vitro. And naman, the results in a lower maximal response to subsequent doses, seen with both short-acting and long-acting B agonists. Yan. Makikita niyo po sa picture. Yan. Then next po, we have yung effect ng corticosteroids. Yan. Ang corticosteroids po is tumutulong para i-reverse yung desensitization by regulating B receptors or ini-increase niya yung receptor numbers, then increasing receptors in the high affinity binding state. Excuse me. Sorry. Then reducing inflammatory mediators. Then potentiating the bronchodilator response. Sabi dito na there is no evidence that B agonists may enhance corticosteroid activity, and showing a beneficial interaction between the two therapies. Yan. Ito tayo sa loss of broncho protection. Ngayon, ang tatakal natin is yung pinagkaiba ng bronchodilation sa bronchoprotection. Pag sinabing bronchodilating effect, ito yung ini-improve niya yung airflow. Yan. Measured by FEV1 or yung PEFR. Pag naman sinasabing bronchoprotective effect, ito yung pina-prevent na yung pag-narrow ng airway na nagre-respond sa triggers, which is yung mga histamine, methacholine, cold air, and of course, mga allergens. And then, meron tayong faster decline in bronchoprotection. The protective effect declines more rapidly than bronchodilator effect. Sabi niya, tolerance developed to bronchoprotection with repeated use of short agents like metaproterenol, albuterol, and terbutaline. Kaya po parang nawawalan na ng bronchoprotection dahil nga po sa paulit-ulit na paggamit ng gamot, ng short-acting na gamot, na nagkukos po na wala na siyang, hindi na siya effective, then nawawalan tayo ng bronchoprotection. O paunti-unting nauubos yung bronchoprotection natin dahil sa palagi nating paggamit ng gamot. Then, after 7 days of regular turbulating use, lower dose of AMP or methacholine were needed to cause a 20% fall in FEV1, indicating syempre yung reduce ng protection. Yan. Then, meron tayong long-acting B or LABAs, long-acting B agonist or LABAs. Yan. Tolerance to bronchoprotection has also been observed with salmeterol, but without corticosteroids and of course yung with inhaled corticosteroids. However, some study shows that walang increase po sa bronchial hyperresponsiveness after 4 weeks and sustained po ang improvement ng lung function and symptom control. Yan. Ang possible mechanism niya po is yung yung mechanism niya po is unclear, but the S isomer of B agonist may contribute to increased bronchial hyperresponsiveness. Similar mechanism may explain reduced maximal bronchodilator response with repeated use. Yun nga, palaging pag gamit. Kaya nawawalan na tayo ng bronchoprotection. Paulit-ulit na paggamit, paulit-ulit, ibig sabihin paunti-unting nawawala yung protection. Yan. Pababa ng pababa. Then, meron tayo itong central nervous system effect, which, sabi dito na, adrenergic bronchodilators can cause CNS-related side effects such as headache, mga headache, nervousness, nagiging irritant, nagiging yung anxiety natin parang nagkikick in, or yung insomnia, which is parang hindi na tayo nakakatulog ng maayos, hindi na tayo nakakatulog. Yan. These effects may result from CNS stimulation or from muscle tremors caused by the drugs. Excessive symptoms should prompt clinicians to evaluate the dosage. Yan. Kailangan na talagang parang i-monitor yung dosage kasi nga nagkakaroon na siya ng side effects sa ating brain, sa ating central nervous system, na baka mag-cause din, if hindi na agapan, mag-cause ng, may lead to death. Yan. Now we have yung fall in arterial oxygen pressure. Sabi dito na inhaled or intravenous B agonists including isoproterenol, albuterol, and salmeterol can cause a temporary decrease in PaO2 during asthma relief. This occurs because beta-2 stimulation increases blood flow to poorly ventilated lung areas, reversing hypoxic pulmonary vasoconstriction and creating a ventilation-perfusion mismatch. The decrease in PaO2 is usually small, rarely greater than 10 mercury, 10 mmHg, physiologically minor and typically returns to baseline within 30 minutes with minimal impact on oxygen saturation. And then, meron tayong metabolic disturbances. Sabi dito na adrenergic bronchodilators can raise blood glucose and insulin levels and lower serum potassium, effects that are more pronounced with parenteral administration. Hypokalemia is mainly a concern in patients with cardiac disease or when interpreting potassium levels. Dito sa metabolic disturbance, yung mga bronchodilators na ginagamit, parang nire-raise na yung glucose and insulin level natin, na nagkukos ng concern sa mga patients with cardiac disease. Yan. The potassium decrease is likely due to beta receptor mediated activation of the sodium-potassium pump. Inhaled beta agonists minimize this metabolic effect because plasma drug level remains low. Then, meron tayo nitong propellant toxicity and paradoxic bronchospasm. Ang MDIs with CFC propellant can occasionally trigger bronchospasm in hyperactive patients. Though it is usually brief, like 3 minutes, the bronchodilator effect of the drug often offsets this reaction. HFA MDIs show similar adverse effects, while dry powder inhalers or nebulizer can be alternatives for sensitive patients. Oral administration is also an option to avoid propellant-related bronchospasm. Then, meron tayo ditong sensitivity to additives. Yan. Individuals with hyperactive airways may be sensitive to additives in bronchodilators solution, especially sulfate preservatives, which can cause bronchospasm by forming sulfur dioxide. Other additives like benzalkonium chloride or BAC, ETDA, and yung pH adjuster can also affect yung airway, smooth muscles. For acute airflow obstruction, additive-free sterile unit dose solution are recommended, and clinicians should consider these additives as a potential cause if bronchoconstriction occurs. So basically, yung mga additives po, um, hindi po siya pwede sa hindi po siya pwede sa mga pwede po siyang gamitin, hindi po siya pwedeng gamitin sa mga patients na may may na may ah, mali, sorry. Um, yung additives po, isa po siya sa cause ng pag may bronchoconstriction yung patient, possibly po na isa yung additive sa cause niya. Yan. And also pala, sasabi dito na pag ang acute airflow obstruction ang patient mo na pag ang patient mo experience ng acute airflow obstruction, dapat walang additive, sterile, at unit dose solution ang gagamitin. Yun lang. Then, meron tayo dito na compatibility of other agent with bronchodilators. Yan. Yan. Sabi dito na ang respiratory therapists commonly mix medications in a nebulizer cup, but most combinations are not FDA approved for mixing. So, dapat, pag nagmi-mix ka ng gamot sa nebulizer cup, sure, FDA approved yan. Dapat, alam mong ginagawa mo. Yan. Studies show certain bronchodilators are chemically compatible with other respiratory medications. Sabi dito na many commonly used respiratory medications are chemically compatible when mixed. Mixing is common practice but it should be done with caution. Kasi syempre, alangan naman makamix ka dyan ng gamot mamaya nung binigay mo sa patient mo na karoon ng side effects. O, diba? Syempre, ikaw ang may responsibility nun. Kaya dapat, pag nagmi-mix ka ng gamot, alam mo yung ginagawa mo, alam mo yung nilalagay mo, alam mo kung paano gawin yon. Yan, sabi dito na extra care should be taken regarding to the nebulizer's type and performance, yung stability and proper administration ng antibiotics na ilalagay mo. Kasi may controversy ang B agonist. Sabi dito na ang asthma paradox. The asthma paradox describe increasing asthma deaths despite better treatments. Tumataas yung deaths ng asthma kahit na maayos or mas better yung treatments. Kasi overuse of short-acting beta agonist or SABAs without adequate corticosteroid therapy may worsen outcomes, increase mortality risk, and raise airway hyperactivity. And drugs like albuterol and salmeterol are generally safe when properly used. When properly used, syempre, kailangan mong talagang properly use ang mga gamot. But, regular use of phenoterol and isoproterenol has been linked to poor asthma control. Kaya, tolerance can develop and regular use may increase bronchial hyperactivity. Sabi dito na ang key idea na nakalagay is B agonists relieve bronchospasm but do not treat inflammation. So they should not replace corticosteroids in asthma management. yes, sabi natin nakakapag-relieve siya ng bronchospasm, pero yung inflammation hindi niya nagagamot. Kaya kailangan talaga ng close observation. Yan. So, then, asthma morbidity and mortality. Yan. The B agonist controversy questions whether B agonists contribute to rising asthma deaths. Current evidence suggests there is no clear class effect directly causing asthma deterioration. However, yung asthma mortality continues to increase worldwide despite improved treatments. Ayan na naman tayo sa madami pa ring namamatay due to asthma kahit na nag-improve yung treatments. There are possible reasons for worsening the asthma outcomes. Una, B agonists may mask symptoms. Yan. Kunwari, walang symptoms. Kunwari, iba yung symptoms, ganyan. Allowing continued allergen exposure and progressive airway inflammation. Yung B agonist parang kung baga tinatanggal or yun nga, minamask niya yung symptoms ng sakit na nagkukos ngayon, syempre, ng diretso pa ring inflammation ng airway mo, hindi mo na alam na may asthma ka na pala, na ganito pala. Yun, bigla kang nategi-bum-bum dahil sa asthma. Syempre, dahil nga dun sa B-agonist na nagmamas ng symptoms. Then, meron din yung temporary bronchodilation can lead patients to underestimate severity and delay medical care. Yan. Yung mga temporary bronchodilators din kasi temporarily na ginagamit. So, akala na, ay, okay na to kasi syempre, nakapaggamot na ako, ganyan. Yun pala, nade-delay lang yung na-underestimate lang yung severity ng yung sakit, nade-delay lang yung medical care. Ayun, parang hindi pinagtuunan ng pansin. Kaya madaming namamatay. And meron din yung over-reliance on B agonist may reduce proper use of anti-inflammatory therapy. Ito naman yung dinedma na yung ibang gamot. Yung sa nagre-rely na lang siya sa B agonist. Hindi niya na pinapakialaman yung proper use ng anti-inflammatory therapy. Yan. Hindi pwede yun. Then, meron tayong accumulation of the S-isomer in racemic B agonist may negatively affect asthma control. Yan. Then, meron tayong environmental pollution, lifestyle changes, and may worsen airway irritation. One thing din po ito, yung sa talagang environment pollution and lifestyle. Talagang kung may asthma ka, then parang lagi may kasama kang naninigarilyo or nagve-vape sa bahay nyo, talagang magwo-worse ang asthma mo. Talagang magwo-worsen ang irritation ng lalamunan mo. Kasi nga, syempre, may kasama ka, hindi man lang nila kinoconsider na may asthma ka, ganyan. Hanggang sa madagdagan na naman ang deaths ng asthma. Hindi pa rin naman sila titigil. Kaya talagang nasa environment pollution din talaga yan. And meron tayo lastly, meron tayo ng respiratory care assessment of B agonist therapy. Before treatment, kailangan assess the effectiveness of drug therapy on the basis of indication for the aerosol agent. Presence of reversible airflow resulting from primary bronchospasm or obstruction secondary to an inflammatory response or secretion, either acute or chronic. Then monitor flow rates with bedside peak flow meters, by portable spirometry or on the basis of laboratory reports of pulmonary function before and after bronchodilator studies to assess reversibility of airway obstruction. Then perform respiratory assessment, breathing rate and pattern, and breathing sounds by auscultation. Before and after treatment, dapat nagagawin yan. O-observe, papakinggan ang breathing rate, pattern, tsaka breath sounds ng patients. Then, assess pulse before, during, and after treatment. So, kumbaga, kailangan mong i-assess yung pulse ng patient bago, during, which is habang nagtitreatment, and after nung treatment, para makita mo kung may pinagbago ba yung pulse niya nung ginagawa mo na, nung before, nung ginagawa mo na, and after after nung treatment. Then, meron tayong during treatment and short term. Ito yung assess the patient's subjective reaction to treatment for any change in breathing effort or pattern. Kailangan i-assess mo din ang arterial blood gas or pulse oximeter saturation as needed for acute state with asthma or COPD to monitor changes in ventilation and gas exchange. Note the effect of B agonists on blood glucose. Increase and potassium which decrease dapat in laboratory values. If high doses such as with continuous nebulization or emergency department treatment are used. Next, meron tayong long-term naman. Sabi ni dito na monitor pulmonary function studies of lung volumes, capacities, and flows. Instruct asthmatic patients in the use and interpretation of disposable peak flow meter to assess the severity of asthmatic periods to ensure there is an action plan for treatment modification. Patient education should emphasize that B agonists do not treat underlying inflammation or prevent progression of asthma. Yan, dapat sabihin mo dun sa patient mo na yung B agonist, hindi niya natitreat yung inflammation or na-prevent yung progress ng asthma mo. Ng asthma niya pala, sorry. And additional anti-inflammatory treatment or more aggressive medical therapy may be needed if there is a poor response to the rescue B agonist. Parang magre-resort sila in another way pag mababa yung response ng rescue B agonist. Then, instruct and then verify correct use of the aerosol delivery device. Mapa SVN, MDI, reservoir, or DPI man yan. Then, instruct patient in the use, assembly, and especially cleaning of aerosol inhalation devices. Siyempre, kailangan mong sabihin dun sa patient mo, dun sa long-term patient mo na, ma'am, sir, ganito po ang paggamit, pag-ayos, like pag-assemble, at paglinis nung device. Kasi, syempre, long-term nilang gagamitin yan. Di naman araw-araw, kumbaga, kahit na na-discharge na sila sa hospital, gagamitin pa rin nila yan, and hindi naman araw-araw kasama kanila, kaya kailangan mong ituro sa kanila yung mga yon. Ngayon, sabi dito na for long-acting B agonist, yan, assess ongoing lung function including pre-dose FEV overtime and variability in peak expiratory flows. Assess amount of rescue B agonist used in nocturnal symptoms. Baga, kailangan mong i-assess yung amount ng B agonist na ginagamit mo sa mga gabi lang lumalabas na simptomas. Yan. And tayo itong respiratory care assessment of B agonist therapy, yung mga hindi pwedeng yan. Meron tayong assess number of exacerbation, unscheduled clinic visits, and hospitalization. Assess days of absent resulting from symptoms. Assess ability to reduce the dose of concomitant inhaled corticosteroids. Then, sabi dito ang general contraindications. Lastly, mga general contraindications. Sabi dito ng bronchodilators are generally safe. However, regular long-term use of short-acting and long-acting bronchodilators is not recommended. Kung baga ang paggamit po ng short-acting at long-acting bronchodilators in long-term ay hindi recommended. Use of bronchodilator therapy in patient with cardiac problems should be closely monitored because once na nagkaroon ng malfunction, kawawa naman yung patient kasi nga cardiac problems basically mahirap, yun ang pinakadelikado. Then patient with chronic diseases such as cystic fibrosis, COPD, and asthma may be less responsive to bronchodilator therapy, possibly because of side effects from long-term use. Yan. Baka magulat ka na, bakit parang hindi gumagana sa akin yung bronchodilator na ito. Yun pala, dahil yung sakit nila is cystic fibrosis, COPD, and asthma. Na ang possibly cause niya nga, yung side effects ng mga long-term use nila. Yan. And that's all. Thank you for listening. Thank you.